All right, hello everyone. Welcome to our weekly COVID update. I'm Carrie Schutte, the Public Information Officer for the Shasta County Health and Human Services Agency, and this is our weekly update about COVID-19. With us today, we have Robin Schurig, the Public Health Director for the Shasta County Health and Human Services Agency, Dr. Karen Ramstrom, who is our Health Officer for the Shasta County Health and Human Services Agency. We have Mike Freeman, representing the Shasta County Office of Education, Glenn Hayward, representing Redding Rancheria, Brandon Thornock, representing Shasta Community Health Center, Robert Folden, representing Mercy Medical Center Redding, and Ryan Waller, representing Shasta Regional Medical Center. Thank you everyone for being here with us today. We will start with an update from Robin Schurig, our Director of the Public Health Branch.
Thank you, Carrie. Good morning, everyone. I will share a little bit about our latest data, starting with cases. The CDC's 7-day case rate is currently 482.01 cases per 100,000 population in Shasta County for the 7-day period of August 24th through the 30th. Again, anything above 100 per 100,000 is considered high transmission, and our extremely high transmission is being driven by the Delta variant, which is much more highly contagious than previous strains of COVID, as well as by the low vaccination rate in our county. For hospitalizations, I don't have yesterday's data yet, but as of Monday, there were 90 people hospitalized with COVID in Shasta County, including 21 in the ICU. And as we've reported previously, the vast majority of our cases, hospitalizations, and deaths have been in people who are unvaccinated. Again, we share this information in order to convey the effectiveness of vaccination against infection, but especially against severe illness and death. Our latest data on vaccination shows that 44.7% of eligible Shasta County residents, so those aged 12 and older, are fully vaccinated, and 54.5% have had at least one dose of vaccine. This is still very low compared to the state as a whole, as well as the nation. Excuse me. Vaccine remains the most effective way for us to protect ourselves, our families, and our community from COVID and from severe illness or death from COVID, including providing protection to those under 12 who aren't yet eligible for vaccine. The Pfizer vaccine recently received full federal approval for people aged 16 and older, and as I mentioned last week, it still has emergency use authorization for those aged 12 to 15 while data continues to be collected. Now that it has been fully approved for 16 and older, it has been given the brand name Comirnaty, but it is the same vaccine that has been given since it first became available late last year. The FDA was able to issue full approval on a shorter timeline than normal because there was so much data available from so many people having received the vaccine while it was under emergency use authorization. And also because the FDA was able to commit more resources to the review of that data to get through it quickly. So they got through the process more quickly, but it was the same process that they would normally use. They didn't skip any steps. And again, just a reminder that whether you're vaccinated or not, it's still a good idea to layer on other forms of protection, such as masking, avoiding crowds, especially indoors, and staying home if you're sick, except to get tested. Those are my updates, and I'll turn it over to Dr. Ramstrom.
Good morning, everybody. Today I'm going to touch on two areas, immunity and COVID-19 vaccination among people who've had past infection, as well as treatment for COVID-19. There's been a lot of interest and varying opinions shared lately about immunity from past infection versus vaccination. So just thought I'd comment a little bit on that. The current recommendation of the Advisory Committee on Immunization Practices is that people with past infection be vaccinated against COVID-19. And I wanted to share some information about the rationale and aggregate science that's informing that recommendation. We've learned a lot about the immune response to natural and vaccine-induced immunity with SARS-CoV-2, and further studies are ongoing to identify the qualitative differences in neutralizing antibody response between individuals, including how other factors contribute, such as age, health status, and re-exposure to different variants. As far as antibody testing, though quality tests are available, there are limitations with testing to clinically measure your individual level of protection. These tests vary in sensitivity, specificity, and quality, and there are considerable inter-individual differences requiring some sort of standardization for these tests for their interpretation to be reliably used. Neither vaccination or a past history of natural infection are protective for all people. Both vaccine immunity and natural immunity are imperfect, with breakthrough infections recorded in both groups. Breakthrough or reinfections are more likely in individuals with past infection compared to those who are vaccinated. And importantly, studies in both the lab and real world have shown that people who've had COVID-19 previously and are later vaccinated are more protected against reinfection than those who once had the virus and are still unvaccinated, including against the Delta variant. A recent US study looked at the history of COVID-19 and found that being unvaccinated was associated with 2.34 times the odds of reinfection compared to being fully vaccinated. And there's also been questions about safety of vaccination in those with past infection. People with a history of COVID-19 more often experience symptoms such as body aches, fatigue, and fever for a few days after vaccination. And like people without a past infection, these symptoms are self-limited and resolve. This is based on tens of millions of persons who have been infected and are included in the overall safety profile of the vaccines. These are the conclusions that apply to the vast majority of the population, and individuals are always encouraged to speak with their healthcare provider about their own individual health condition. In terms of treatment of COVID-19, I'm going to just sort of do an overview of the medications for treatment based on the National Institutes of Health Expert Panel for COVID-19 treatment guidelines. These are the medications that have been shown to be safe and effective and have either FDA approval or emergency use authorization for treating SARS-CoV-2, the virus that causes COVID-19. In terms of prevention, vaccination is the only way to prevent infection. There are no medications effective at preventing infection. For outpatient treatment, there are currently 2 monoclonal antibody regimens recommended for high-risk individuals with mild to moderately severe COVID-19 illness and not requiring hospitalization. One of the monoclonal medications, REGEN-COV, was recently added to the emergency use authorization for use in high-risk people who've been exposed to someone with COVID-19 to prevent them from becoming very ill or going to the hospital. So that's great news. There are no oral medications recommended for outpatient use. For hospitalized patients, a combination of medications are typically used depending on the oxygen and ventilator needs of the patient. Remdesivir, you might recall, was one of the earliest medications that received a lot of attention. It's an antiviral medication, and it's the only drug to have full FDA approval for treating COVID-19, given intravenously to patients in the hospital who have a need for oxygen, but who are not on a ventilator generally. Dexamethasone is a steroid, kind of like prednisone, that can be used alone or in combination with remdesivir. It's usually given IV, but can be prescribed orally for people discharged from the hospital who meet certain criteria. And then there are 2 medications that are typically used for treating people with rheumatoid arthritis and used to treat COVID-19 hospitalized patients with signs of systemic or whole body inflammation. In terms of medications that have not been shown to be effective at treating COVID-19, those include azithromycin, doxycycline, hydroxychloroquine, and ivermectin. And I just want to provide a word of caution about ivermectin. There have been many nationwide and local reports of side effects resulting in emergency department visits and calls to poison control centers related to taking ivermectin. These side effects are often due to inappropriate route of use, so somebody taking a topical medication orally or taking formulations or doses that are not appropriate for human use, as well as children accidentally taking ivermectin. A recent clinical trial confirmed prior studies that showed no benefit of ivermectin, and concerns continue about toxicity of this drug. Studies are ongoing for this medication and others. And then I just want to close with 2 comments. I want to just put out a huge thank you to our healthcare personnel. They're taking care of these patients as well as all the other medical needs of our community members, and they're exhausted and continue to step up. And I think, we all need to do our part to reduce transmission in the community, to reduce the strain on our healthcare system and providers. And then in terms of children, I just wanted to share a comment I heard on a healthcare provider call yesterday by a pediatric intensive care physician. He takes care of people who have been, children who've been critically ill with COVID-19, and quote, he said, "Protecting our kids needs to be paramount." And I just thought that was so telling, coming from somebody who's taking care of these kids who are getting really sick. We've been fortunate here so far, but we are not immune to having our children impacted. I think it makes clear the importance of prevention measures for our children, particularly for our kids who are in school and their families. So masking, staying home when sick, and vaccination for those who can do that. Schools are still experiencing concerning numbers of cases, and we continue to need the community's help to reduce exposures and transmission in the environments in which students and staff live. And this takes all of us to contribute. And that's all I have today. Thank you.
All right, thank you, Dr. Ramstrom. We also have our representatives from our hospitals, healthcare partners, and education. Do any of you have an update you would like to share with us this morning?
I just want to remind the community that as part of the public health order, we have implemented screening for visitors. So under that public health order, folks either need to be fully vaccinated or have a copy of a negative test result. So, we're trying to work with people, but that order has been out now for almost 2 weeks. The other is that the emergency room, we're here for folks when they have medical emergencies, but the emergency room is not a good place if you just need to get a COVID test, or if you're interested, curious about the monoclonal antibody therapy. We are working on an off-site monoclonal antibody therapy type clinic. But for those folks that are interested in getting testing, I would encourage people to go to shastaready.org and take a look at those testing sites. We are seeing on any given day, there's half a dozen people that come into the emergency room just for testing. And that is not a good use of those resources, especially since we're dealing with, a fairly high level of activity here in the community. We're here for emergencies, but COVID testing is not a medical emergency.
All right, anyone else?
Yeah, this is Brandon at Shasta Community Health Center. I just want to echo a little bit of what Robert just shared. We too have seen quite an increase in a number of individuals from the community who are coming to the health center looking for testing. I think people really need to go to shastaready.org and see what's available. I mean, when we look at our patients, we see roughly 600 patients a day in our centers, and we're screening out just the patients who have appointments, roughly 60 based on their symptoms. So we really don't have the staff to accommodate our own patients as well as the majority of the community. But the county has done a nice job in setting up the website and finding resources for folks. So please go there.
All right, thanks, Brandon. Anybody else?
Yeah, here at Shasta Regional, we had two things. First off, the hospital has been noticeably busier, especially in the ER, but our staff has done an amazing job. They're working hard. They come in and day out, just putting their heads down and getting the job done. So they are there for the community. And so any chance you get, show your appreciation to them. They are, they're doing their best here through this surge in COVID. The second thing is, if you do have an emergency, come in early so we can treat you and hopefully, prevent you from getting sicker. We do want to make sure that we are here for you, can treat you early, and don't wait until you're so sick that you need intensive care.
All right, thanks, Ryan. Anybody else? All right.
I can jump in. Yeah, so Mike Freeman from Shasta County Office of Education. I just want to piggyback on what Karen Ramstrom was sharing about COVID among kids. This is clearly a different COVID reality than where we were last year at this time. We are, again, I'm with healthcare professionals. I don't want to sound like a healthcare professional. I'm not, but we are seeing increased student transmission rates. I can give you some numbers. We have currently just point in time data as of this morning. We have 2,018 students in some form of modified quarantine. 1,143 students were in quarantine at home. 302 positive cases among students. 82 school staff at home on quarantine. 49 school staff experiencing a positive case. So you can imagine what that is doing to our schools. We do have currently one school in the county that is closed. We did have one closed temporarily earlier this week due to staffing. Staffing Staffing demands is a huge concern among schools. In fact, I would even put many schools on the brink of program closures because of staffing. If you do the math, going in, so 131 staff home either due to positive or quarantine, add to that 224 vacant positions across the county in schools, whether that's teachers, paras, support staff. So our school staff are stepping up to the challenge, and the challenge is it's monumental. And we really do appreciate the work that they are doing to keep schools open and to keep students on campuses. We did recently have over 120 participants joining up with public health, county public health staff to discuss our current reality. And county health shared with them some recommendations to schools above and beyond the guidance, because the guidance allowed us to maybe make some changes in school classroom environment compared to where we were last year. But the recommendations are bringing back things like cohorting, eliminating non-essential visitors on school campuses, eliminating non-essential activities. A lot of back to school nights went from in-person to virtual in order to mitigate transmission. We are seeing trying to do everything that we can to promote vaccination, trying to promote at-home symptom monitoring and screening. These things are going to help us if we can partner with parents. We are experiencing the modified quarantine is becoming less of an option for schools because of the number of close contacts and the lack of testing resources. We just don't have access to the testing resources to be able to accommodate that. So many districts are shifting to full 10-day quarantine. So staffing, testing, and then trying to increase those mitigation efforts above and beyond the current guidance is what schools are doing to respond. But it is definitely a different COVID reality right now on our school campuses. So shout out to all of our school personnel for trying to keep the lights on, keep the doors open, keep kids on campus.
All right, thank you. Anybody else have anything to add before we go to media questions?
I just want to add one more thing.
Sure.
I would just encourage the citizens of our community to just be extremely patient as they're reaching out to our healthcare facilities. I know I'm not alone in this, but we're experiencing extreme staffing shortages. And with the vaccine mandate, I know some of the other facilities where they have a lot more employees, they're looking at bigger numbers, but we're still unsure about 140 of our staff, whether or not they're going to still be with us after September 30th, when the mandate goes into full effect. And so we just really ask for patience. A lot of folks are getting frustrated, and ourselves included, but we're all doing everything that we can to accommodate folks as we can. So just a shout out for patience out there and a little bit of understanding.
Excellent advice, thank you. All right, I think we are ready for media questions.
I've got a question for Mike Freeman. Mike, is there a tipping point? Do you do this by district, or would it go by school as far as, closing down either temporarily or going back to virtual learning?
Yeah, great question, Mike. I think that as with everything COVID, we're really relying on the partnership that we have with our Shasta County Public Health in communicating the current realities that schools are facing district by district. With staffing shortages are going to determine closure for short term. When we get into case rates, that's going to be working closely with public health to determine what that looks like and for how long. But right now, the closures that we are experiencing are due to staffing, not having the people available to be able to run the school. This year it is a little different because last year we had a couple of different tools and options available to us, distance learning being one of them. This year distance learning is not available. Legislation has taken that away. AB 130's made some changes to our independent study. So it's quarantining, it's in class, or it's independent study. And those are the options that schools have available to them. So last year, where you may have seen a classroom shut down for a period of time or a grade level shut down for a period of time, those schools could pivot to a distance learning environment. That option is not available to us, so that pivot is not available. And so when schools are closed, when kids miss school due to quarantine, districts are scrambling to try to put together independent study plans for them. When schools close, entire schools would have to go on independent study in order to capture the learning that's lost.
I forgot from last week, could you define modified quarantine?
Yeah, it's a great question too. So modified quarantine, the plan was, again, we are running into challenges with modified quarantine. So I'm a little nervous even talking about it, because if a parent hears that modified quarantine allows their students to stay on campus and they go running to their school administrator saying, hey, where's that option for my kid? That may not be available to them because of the number of close contacts that we're experiencing and the lack of testing. Because under modified quarantine, a student can remain on school campus wearing masks, as all kids are wearing masks, all school personnel indoors are wearing masks, as long as they're asymptomatic and agree to be tested 2 times in the next 7 days. That would be the plan for modified. So as you can see, if you don't have available testing resources, that modified option becomes unviable real quick.
Thank you, Mike. One more. What's the school that's closed?
Castle Rock currently is closed.
Okay, but that's temporary.
Yeah, Anderson Middle School was closed earlier this week due to staffing, and they were able to open the next day. Castle Rock is closed, I believe, through September 7th.
Thank you, Mike.
And I just want to put a shout out to our, Shasta County. We're Fall River. We're Castle Rock. We have a wide spectrum of schools with different sizes and resources, and so some of our smaller outlying single school districts, when they get hit, when some of these districts can have 4 or 5 families impacted, and that's going to be enough to determine whether they can stay open or not. So Shasta County has a wide variety of educational settings, a wide variety of healthcare needs, and so we're definitely experiencing that spectrum of district response. But I can tell you that many programs are on the brink. Many programs are looking at how long can these efforts be sustained. And so Judy Flores is working with the state to have discussions about what resources and tools might be available for districts to help them pivot, because we don't have a lot of options.
Would that be smaller districts or the larger ones as well?
Different, varying degrees, right? I think larger have scrambled. In the case of Anderson Middle School, for example, Cascade's one of our largest school districts. They were closed. They were closed for 1 day, and they were able to move some people around, and they were open the next day. But large and small are all feeling it. In yesterday's call with Public Health, we had 120 school personnel, and everyone had a story. Whether it's principals jumping into classrooms teaching, or setting up tables for cafeteria because janitorial staff are down. It's a whatever it takes, and all hands on deck. And eventually, we need people in order to do this school thing, like the hospitals, like Brandon was saying. We need staffing, and we need patience as well. We need people to be patient with us, because what you see happening at school is sometimes it's folks jumping in to do whatever it takes to keep the lights on.
Is it fair to say the larger the district or the larger the school, the more likely it can stay open, or does that really hold?
I'm a little leery of saying something like that. Larger school districts may have resources available to them that will allow them to be a little more nimble, a little more flexible.
Thank you, Mike.
Yeah.
See, I'd like to jump in. Mike Chapman from the Record Searchlight. My questions relate to bed delays at the hospitals, not just for COVID, but for other treatment, trauma, cardiac issues. We listened to the scanner here at the Record Searchlight, and for the past couple of weeks, I've been hearing a lot of level zeros. And so I reached out to an AMR spokesperson, and he was saying it's not unusual for ambulances to wait 2 to 3 hours outside a hospital before a bed is available. And so I was wondering if the hospital spokesman can talk about the bed delays and what's bringing that on.
Yeah, I'll jump in here for just a minute. So I think the one dynamic first off is it's not entirely uncommon in busy seasons of the year to have issues like this. But what we're seeing right now is the sheer volume of cases that are coming through our ER. And remember, ERs often act as a backstop to some of our primary care or the lack of primary care resources in our greater community. So when I mentioned earlier about, this isn't the greatest, the emergency room is not the greatest place to come to just get testing, we get some of that dynamic as well. So yes, we have times when we're holding, let's say, mental health holds that are being evaluated. We still take care of our community for trauma, stroke, STEMI, all of those things that occur that are unexpected. But we're also seeing many patients that truly are sick with COVID. So it's a combination of things. It's not just because of COVID volumes. So when the perfect little storm develops and we've got our 30 beds occupied within the emergency room, we've talked before about those other treatment locations that we'll use. We'll have folks in a corridor within the open space of the emergency room. And unfortunately, when an ambulance arrives and they have a patient and I don't have a bed for that patient and they're not one of the most critical, unfortunately, that EMS crew has to stay with that patient to make sure that they have an appropriate level of care. So that's not uncommon really at any of our hospitals right now. Doesn't happen all the time, but it does, unfortunately it happens. We don't ever want it to happen, Mike, but unfortunately it does.
Yeah. This AMR spokesman was saying it's not just directly COVID, but like for some of the ambulance crews, and Mercy has ambulance crews. It's the ambulance crews, they're exposed to COVID, so maybe they have to quarantine, or maybe their families are sick and they have to quarantine, or they're sick themselves. And so the spokesman was telling me also at the hospitals there's a nursing shortage because of the same sort of issues, like they've gotten COVID or they've had to quarantine. Is that playing into the issue, the problem?
Yeah, so I'm going to speak for my hospital and speak for our ambulance service because it would be inappropriate to speak for SRMC and AMR. But I know that we currently continue to run the same number of ambulances that we typically run. And I spoke with Jason Swan this morning. We run four ambulances during the day and 2 at night. And there are some times when we're able to run a 5th ambulance during the day. So we continue to do that. We haven't had a major issue. There is a national shortage of healthcare workers, whether it's RNs, respiratory therapists, clinical lab scientists, EMTs, or paramedics. So I think all of us across the board are challenged from time to time with one specialty or the other. And I'm not going to sit here and tell you that we haven't had our own employees, let's talk about a registered nurse, for instance, or an EMT in this case, who haven't come down with COVID. But that's not impairing our ability to staff our ambulances at this time. It makes it really challenging inside the hospital when we are full to staff around the clock. So sort of like what Mike was just speaking to, what they have to do in the school systems, we're doing the same things. You know, we've got quality nurses that maybe haven't worked at the bedside in recent times that are helping out on the floors. We have nurse shift managers taking patient loads. We've got managers and directors coming in to provide support. As much help as I could be this weekend, I was here all weekend to help, if nothing else, just to buy some coffee to give people a break or answer the phones for our house supervisor. You know, we can all play a part. And I think that's kind of been the beauty, at least here at our hospital. I've been really proud with how well people have come together to meet the need of the community.
Okay, great. Yeah. Yeah, maybe Mr. Waller, can you answer some of those same questions from SRMC's perspective?
Yeah, so a lot of what Robert said applies to SRMC, but I don't think it's fair right now to say that 2 to 3 hour waits are the new normal. We do have days where, you know, that ambulance that's not as critical as some of the patients out in the lobby are waiting for beds, and we have to prioritize who's sickest within the departments. We are, just like Mercy, is working alongside our ambulance partners to try and prioritize when they tell us that, hey, there's calls pending in the community, no ambulance is available, what can you do for us? And we, you know, we'll extend our staff out and do what we can to get those ambulances clear so that they can be back in the community and responding.
Okay. All right.
You know, Mike, the other dynamic is when an ambulance crew brings someone in, we have to clean the ambulance before they can go back out.
Oh,
So I think in a normal run, that could be a 20-minute process. The challenge with transporting a COVID patient is that it's a whole different cleaning process. So we actually we fog the interior of our ambulances, which means they have to have a dwell time, or they have to sit dormant, and then they have to be wiped down. So from what I understand, that can easily take 45 minutes. So that adds to time that prevents an ambulance from being out in service.
Yeah, okay. That explains the AMR spokesman saying, you know, they have to decon. I guess that means decontaminate then.
Yeah.
Okay. All right. Well, that kind of answers my questions with well, one quick other question is, you know, with the ambulance delays, if it gets bad, I mean, the AMR spokesman said it ebbs and flows, but have you had either hospital had to send patients to other hospitals or have a life flight because things are so bad?
So, you know, we talk all the time about our trauma service. So remember, we only have certain capabilities here in Redding. We're a level 2 trauma center. I've got some pretty fantastic surgeons. We've got 2 orthopedic traumatologists that many communities don't have. But from time to time, we get level 1 traumas that have to go to a larger center. There are times when people have injuries to their eyes or you know, specific conditions that require them to go to a university. So it's not uncommon on any given day and any given week that folks need to go to a higher level of care. I will tell you, we were stretched pretty thin on Friday, and we still managed to respond to the Region 3 call for assistance when a hospital in our service area, which comprises much of Northern California, had a critical failure. But we still took an ICU level patient because we have to. If there's one thing we need to do, it's respond when in a time of crisis, especially when one of our partner hospitals is having an event at their hospital. So they needed 4 patients cared for, and we immediately accepted one of those patients, even though our ER was already full, even though our physicians were already kind of feeling the pressure with the load that they have. It's what we do in EMS. SRMC has come to our aid from time to time, just like we come to theirs.
Okay, just one quick question. You know, these days, it's not just COVID, but the ambulance service, also they're dealing with respiratory issues with the smoke. I mean, is that something you've seen at ERs or in your hospitals?
feels like we see that almost every summer. So yeah, this is nothing new. We've been dealing with this for years. I think back to 2008 when we had our first big event here in Northern California where Highway 36 was closed, Highway 299 was closed. The only way we could get home from the coast was going up into Oregon. So these are things I think that our agencies are used to dealing with.
So we have just a couple more minutes. Do we have?
Okay, I'm done. Thanks.
Okay, awesome. Thanks, Mike. Anybody else?
Hi.
Hi, Anna.
Hi, sorry, Carrie, to cut you off like that. I just wanted to follow up on something. Robert, you said something about seeing increased testing, people looking to get COVID tested more at your hospital. Sorry, I just wanted you to elaborate a little on that.
I think we're seeing that in the community, and it's not uncommon for folks to come up to the hospital. Like I said, we probably have 4 to 6 patients a day that come up primarily to just be tested for COVID. So, you know, a hospital emergency room really isn't the place to do that. That's our community clinics are set up to do some of that. And again, there are resources that are available through shastaready.org where you can go get tests. There are even over-the-counter test kits that are just as reliable.
Great,
So
thank
while
you.
we're here,
Sorry, go on.
no, I was just going to say, you know, Shasta Regional and Mercy are both here for folks that are having emergent medical conditions. But if I just need to be tested for COVID, I think I would call my family physician first or call my clinic first before I went up to the ER.
And I don't know if you mentioned it earlier, but when people come up to the ER, you know, asked to get COVID tested like that, does that kind of put a strain, and this is for either Shasta Regional or Mercy, does that put a strain on the resources for the hospital? Because that could be going towards emergency critical care, you know?
Yes.
All right. Anna, do you have other questions?
Yes, one more for Shasta Community Health Center. Brandon, this one is for you. Dean mentioned last week there was like a strain of or issue getting more testing supply kits. This week or this time, are you seeing still an issue getting more testing kits? Because we are seeing that increased need in testing within the community.
Yes, absolutely. And so what we've had to do is explore other brands that we haven't used in the past. Just really scrambling, trying to find whatever testing kits we can. And the issue for us, and I think for a lot of others, is complicated, or it's a bigger issue than it really would have need to have been had there not been a mandate that for those that are unvaccinated, they have to get tested every week. Because, you know, you're looking at us 500 employees, so we've got a lot of patients who we need to test as they're coming in and showing signs and symptoms. But we're also using weekly, you know, about 200 of those testing kits on our own staff. And so it just it's a bit of a struggle, and honestly, that's a core reason why there's a lack of access to these tests across the state and really across the nation.
And then just want to follow up one more thing. Dean also mentioned last week he saw a lot of families, parents, and kids coming to get tested, you know, checking to see if their kids had any symptoms. Are you still also seeing a lot of kids and families coming through the clinic looking to get tested also?
Yeah, absolutely. And they're specifically more common than not looking for a letter from their provider to grant them access back to school, right? Some of the challenges with that is that they'll come in and depending on how long they've had symptoms, that can determine which test we can use. And then there can be, you know, delays if we have to send out tests. And so that can be a bit of a lengthy process given each individual situation. But the demand for that service has increased tremendously.
All right.
Perfect.
Brandon, that's all the time that we have today. I wanted to thank all of you for being here with us. And it seems really important to just issue this reminder back from the very early days of COVID that the reason that all of these things are happening that you're hearing about today is because COVID is spreading in our community, and we can stop that spread by doing a variety of things. Of course, get vaccinated if you're eligible, wash your hands frequently, clean your workspaces and your phones and all of the things that you touch on a regular basis. Stay home if you're sick, and wear your mask in indoor spaces, even if you are vaccinated at this time. With this as much spread as we have, it really is one of the best ways to protect ourselves from COVID. And all of those prevention measures that we were using before the vaccine was available still are really, really important to use right now. Doing all of those things will help us stop the spread and stop this impact on our healthcare systems, our schools, our community. So again, shastaready.org is a place to find all kinds of resources about vaccine, testing, prevention, all of those different types of things. And as always, please let us know if you have any questions. Thank you everyone for being here, and everyone stay safe and healthy.
Thank you.
Thank you so much.